Welcome to DC Hours, the podcast powered by DC Hours Chiropractic Academy. Hosted by Dr. Guy Annunziata, this show delivers cutting-edge insights into the world of chiropractic care, neuroscience, and continuing education. Each episode explores the principles and techniques that define excellence in the field, with interviews, real-world cases, and in-depth discussions that inspire and inform. Whether you're a practicing chiropractor, a student, or a lifelong learner, DC Hours is your trusted source for professional growth and clinical mastery.
Hello, everybody, and welcome to today's podcast. Today's topic is the vital role of soft tissue in chiropractic, and I'm really excited about today's guest. He's been a chiropractor for almost 40 years. He works with some of the biggest names in sports. He's been working with the New York Giants for 23 years. He spent time with the Yankees, the Nets, the Rangers, and a bunch of Olympic athletes, like the U.S. bobsled and women's hockey teams. But the best part about it is he doesn't just treat athletes. He's actually an athlete himself. He's played football, track, rugby, over 200 triathlons, which I find amazing. I've done 2 triathlons, and that was enough for me. 11 Ironmans, the New York City and Boston marathons, and he biked across the country as part of a relay team, and they raised over $800,000 for wounded veterans. He's got some amazing stories. I'm really excited to hear some of these. So let's dive in. Welcome to the show, Dr. Robert DeStefano.
Thank you so much for having me. I appreciate it. And I'm excited to be able to share some things.
Awesome. Well, let's go ahead and get started right with the big question that I think a lot of people want to know is, we know chiropractors really do a good job adjusting joints, right? I mean, I went to chiropractic school, the whole thing was about adjusting. But they still struggle with these stubborn, reoccurring cases. I'd like to know, why do you believe that soft tissue work is kind of the missing link in a traditional chiropractic case management, especially when it comes to these chronic and reoccurring issues that are so stubborn?
So even when I was in chiropractic college, I went to Palmer, graduated in 1986. And while I was in school, I really felt that muscle was an integral role in what was happening. I was on the rugby team, and a lot of us were doing soft tissue, but back in the day, the only soft tissue we had was Nimo, or we would do a little soft tissue associated with motion palpation. But as time went on, I felt that we were falling short on some of these muscular issues. When you look at our vertebra, all those little sticky out things, transverse and spine, they all have muscles attached to them. And we're made of 300 pairs of muscles. So I felt, particularly in one-sided athletes, if you're not addressing muscular imbalance, you are not addressing the full global picture of what's happening. And there are really different schools of thought. I was the SICA president when I was in school, so I was a really strong believer in chiropractic, sticking to manipulation and chiropractic. But I still felt soft tissue was still in our ballpark, because without using a modality, you can do manual work on soft tissue, which is still hands-on chiropractic. Often I was met with resistance, because a lot of people believe if you get the spine right, then muscles will calm down. However, and that it can be true, if the structural component of a vertebral subluxation complex, if the structural component is the main cause of dysfunction, then of course, if you fix that, you're going to fix a lot of things. But if you deal with one-sided athletes like baseball pitchers or people that are golfing or tennis, what you're going to find is that you have an overload of one group of muscles that are pulling on the vertebra, locking up a particular facet. And if you manipulate the joint and don't fix the muscle, you're just going to keep that cycle going and going and going until you break that cycle. So I felt very early on, and I did a lot of research. Interestingly enough, Raymond Nimo and Janet Travell actually did work together along with at the end of Ida Ralph's life. So Ida Rolf, Raymond Nimmo, Janet Travell, they were all kind of part of this movement of soft tissue work. And Raymond Nimmo doesn't get credit for it, but he was one of the first people to use the term trigger point. And then, of course, Janet Travell made it very popular in myofascial pain and dysfunction in the books she wrote. So, trigger point's a real thing, and we all know it exists. But up until the mid-90s, late 90s, when the concept of pinning and stretching a muscle became popular, and Mike Leahy started active release, and he took the concept of pin and stretch and really organized it in a very systematic way that could be taught and could be utilized. And then after that came orthopedic massage, which is very similar to the pin and stretch concept. And now, 40 years later, there's several techniques that are teaching pinning and stretching muscle, which I found to be one of the more effective ways of breaking up soft tissue.
Yeah. So it's funny you mentioned Raymond Nimmo. I went to Life University and I graduated in '92. Back then, very, very strict about we don't treat muscles, we don't talk about muscles. And I stumbled across Raymond Nimmo's work and I was fascinated by it. I forget the name of the lady who was teaching it at the time. But she was great, and she really turned me on to Nimmo. And then I read the Travell books, and I was a big proponent of trigger point therapy and how it fits so well with chiropractic. It just made total sense to me. But I'm just curious to know. So, we talk about Nimmo, we talk about trigger points, but things have evolved since then. You've actually, mentioned some things like pin and stretch, which, to be quite honest with you, Doc, I am not familiar with at all. And I was wondering if maybe you could talk us through what pin and stretch is, how it works, why it's such an effective tool in your practice.
Pin and stretch, the first verbiage of using pin and stretch comes up in massage therapy in around the 1920s. And then myofascial release kind of evolved in the 70s, where Barnes was a big myofascial. He was a physical therapist who taught myofascial release. And there were different types of myofascial release. You could have a muscle static where you just strip it. And then you could have a muscle where you're pinning it and then moving it in different directions. And then you could have a muscle where you actually shorten it and work on the tendon. And then that kind of springboarded work like active release, which is strictly an active pin and stretch. So they bypass the static stripping like Rolfing. And what they do is they find a muscle that's developed scar tissue or has tightness in it. They shorten the muscle, pin the muscle, and then lengthen it under pressure. And what that does is realigns fibers, for lack of a better description. If the analogy I use is if you took two pieces of steak and Velcroed them together, which would explain the macro movement of myofascial planes, like hamstring over IT band, for instance. If you Velcroed them together, how would you separate them? Well, if you just pressed on them, that wouldn't do anything. Although trigger point does work in a different avenue through spinal thalamic tract and neural input. But if you took those two pieces of steak and rolled something over it, that wouldn't do anything. But if you took one piece and the other piece and pulled them apart, that would separate the fibers of the Velcro. So what I see very often are athletes that have either an acute trauma, like a hamstring pull, or a chronic repetitive trauma, where the fibers, instead of the active myosin being able to glide, they kind of bind together like with the myofibrils or the fibrinogen. And when those muscles get stuck together, that inhibits the full movement of the muscle, which pulls on the origin and insertion, which causes tendinitis and pain and dysfunction. So if you find a muscle and you shorten it and you pin it and hold tension in the opposite direction, now you can really stretch that muscle on both a cellular level and on a macroscopic level.
So when you say pin, you're talking about putting pressure, like pinching it and then moving the muscle.
So for instance, if you were doing bicep, You would
Right.
shorten your bicep,
Mm-hmm.
pin it down, and then hold tension in the opposite direction and lengthen the muscle.
Okay.
And you're not doing glide, you're just holding tension on it.
So how does that differ from active release technique, or is it the same
It's the
thing?
same. Active
Okay.
release is a form of pin and stretch.
Okay. I
So-
didn't realize that.
Yeah, pin and stretch is the big umbrella. And active release is a treatment protocol that fits under that. Now, I taught active release for 17 years. So, yeah, I taught over 100 seminars, and Mike and I were very close. And the concept of pinning a muscle and stretching it was already in existence, but Mike took these concepts and put them into a very, very organized, systematic way of teaching, which I feel to date is still the best way of teaching it. You know, it's very concise, it's very well put together. But orthopedic massage also does the concept of pinning and stretching.
What does it take to become certified in ART? Is that
I haven't taught probably for the last 14 years. I taught from early 90s up until about 14 years ago. But you have to take all three portions, which is upper extremity, lower extremity, and spine. And you can get certified in each one of those. But when you take all three, then you're full body certified. And then since then, he's had other courses added, which are more advanced.
I know it's very popular now. I know a lot of chiros that are doing it now and taking the courses. I when I was going through school, I didn't know anything about it. All I knew was the Trigger Point by Nimmo and Travell. But it sounds pretty interesting.
And when you graduated, it was really in an infancy. The first really concise, organized seminar was done in the mid to late 90s. So it was just starting to come to the surface when you graduated.
Let me kind of switch gears here for a second. You had started early on in this conversation. You had mentioned the fact that there could be a joint restriction. That's the primary problem. But then again, there could be soft tissue. That's the primary problem. When you're approaching a treatment plan and both are present, do you address the soft tissue first, the joint, or does it depend on the case?
That's a good question. I almost always do soft tissue before I manipulate, because what I found is if you loosen the soft tissue, even if it's not the primary source of a problem, your manipulation is going to go so much easier. And it makes sense, right? If you have your semispinalis muscle groups in your thoracic spine, that's really tight, or your longissimus coli, or any muscles in the cervical spine that are short and tight, it's going to limit motion. So if you loosen that muscle up first prior to manipulation, you're going to need so much less force to get that joint to move. So I usually address both. And within my history, and then again, the clinical exam, you can figure out what really was the causative factor and what was the side product, like what caused it, and then what was the result of that causation. So you really can, after you do it for quite a while, you can really figure out, was this a structural issue first and then muscular second, or was it muscular first causing a structural issue?
And stretching, does it play a role in any of this?
It does. It's funny because I used to think stretching, particularly static stretch, really was a futile effort. And then when I was writing my book, I did a lot of research, and I spent a lot of time with the Whartons, who are, they created dynamic stretch, and they had a whole systematic way of stretching, worked with a lot of Olympic athletes. And their whole thing about dynamic stretch made a lot of sense, which is bringing a joint through a range of motion and then relaxing it, and doing active stretch first, stretching and holding it. So in my experience, what I found was that static stretch works well in three departments: in post-surgical care, where you really have to break up scar tissue and extend the length of a joint that's been subject to surgery to stop scar tissue at the joint level. Or if your sport demands a really increased flexibility, Somewhere along the lines, we taught people increased flexibility is increased health. And that's not true. Because, if I'm a marathoner, I don't want to be flexible. I want to be compact and I want all my energy to be going forward. But if I'm a gymnast, now I need a lot of flexibility. So I think flexibility is based upon what sport you're doing. So I found that if your sport demands a lot of flexibility, or you're post-surgical, or there is an injury to the capsule, then you need to do some static stretch to really get that loosened. But recreational athletes, I think, really need to warm up and do active stretch more than static.
And when you say active stretch, are we talking about like a PNFT type thing, proprioceptive neuromuscular facilitation?
No, although I think that's good in a lot of cases in post-surgical. No, an active stretch would be, if I'm stretching my forearm and bicep, instead of just stretching it out and holding it, what I want to do is go to the end range, lock it out, and then come back again. So in hamstrings, you're going to straighten your leg and then bring it back. And if you look up the Wharton School of Stretch, they do a lot with dynamic stretch. And they really turned me on to stretching in a way that's more active, which makes sense. That's the way we move. No one ever runs like this and stays. We're moving, we're dynamic creatures.
Exactly. So where does PNFT fit in?
So I think that really fits in well when you have limitation and joint restriction. So if someone has a frozen capsule, whether it's in the hip or the shoulder, or, excuse me, you need to increase range of motion due to a prior injury. That whole like pushing against you, holding resistance, and then stretching further. They've proven when you stimulate the antagonist of a muscle, then the opposite side is going to also relax. So if you push against me with a hamstring and then I can go up further, I'm pushing down with my quad. And now that same kind of neural pathway can help the muscle relax.
So what's your thoughts on massage guns? These new things that are coming out now, where they're just
great question.
Banging. I love the way they feel, but I'm not sure. Are they therapeutic?
It drives me nuts. They're selling a lot of equipment, including foam rollers, with no real good instruction. And it would be like getting an advanced piece of machinery with no direction, and you have no idea how to use it. So where I found, we have a ton of hypervolts and all sorts of massage guns with the team. And where I found them, and the athletic trainers will agree, where we found them really successful is if your muscles are overworked. Like, for instance, I'm training for a marathon and my quads are sore and my hamstrings are sore. With the larger ball and rolling it over and going back and forth, that helps break up intracellular inflammation and gets rid of exudates and things like that. But when it comes to an injury, when you stop and think about, well, what is an injured muscle? Well, a pull is really a tear. And when you tear a muscle, it gets local inflammatory response. It's a little angry, it gets tight. So if you jackhammer that, you're really not helping it. You could actually aggravate it. So what I tell my patients is, if you have a massage gun and you're sore for training, it's fine to use. But if you have an injury, like I had a patient coming in using the massage gun on their C-spine, just jackhammering away. And then they started developing numbness down their arm because, they were pressing on the nerve roots. So I think they're really good for tight, sore muscles. But when it comes to injury, leave it alone with a jackhammer.
What's your thoughts on when you have an injury, like a hamstring injury? And I know my personal trainer is he's a runner and he had a hamstring injury, and he's also he's learning physical therapy. Like he's really moving up in learning all this stuff, and he does a lot of research, and he's a strong proponent of what's the word I'm looking for? Stressing the muscle as soon as you can. So in other words, you have a hamstring injury, as soon as you can, you should load the muscle. What are your thoughts on that?
So it really depends on the complexity and the area and what the injury was. So if you have a tendinosis, for instance, which is fraying of the tendon, an inflammatory process of the hamstring tendon, or even a partial tear, you definitely don't want to load it right away because that's fragile and it can tear further and you can cause more damage. If you have a mid-substance tear or a mid-muscular tear, I think it's important to do movement, but I don't think it's important to stress it. So we'll get people on the bike right away, on the elliptical. But if you have a minor strain where the tissue is not really damaged, and the muscle's intact, then I think loading it can really develop some strength and stop the muscle from shutting down. But there's a lot of different schools of thought about this. But I think about things in a logical manner, like really assess where's the injury located, what is the extent of the injury, and then how do you want to rehab it?
So it really kind of depends on the case. It's a case by case basis.
Yeah, definitely. And we were talking about stretch. The reason I wrote my book was because I took the concepts of pin and stretch and developed a self-treatment protocol. So there are certain muscles, certainly not all of them, but there are certain muscles where you can apply that principle of pinning and stretching to yourself. So for instance, I have patients that use lacrosse balls all the time. And a lot of times they use them incorrectly because if I'm using a hamstring, for instance, they'll take the lacrosse ball and put it on the hamstring and just press on it, roll around. Well, again, that's not always going to break it up. But if you take that lacrosse ball and put it on your hamstring, just distal to where the injury was, because you don't want to put it right over it. But if you put it distal to the injury and then put a little pressure and then straighten your leg, now you're doing that pinning and stretch and you're stretching the injury distal to where the muscle where the injury was, which now can increase flexibility of the uninjured part of the muscle, which will take tension off of the injury. So I think doing some self-pin and stretch really can be helpful. There's protocols you can do for the glute, for the hamstring, for even iliopsoas. You can, people ask me all the time about the hook. They have that psoas hook.
Yeah, I know what you're talking about.
It's a great idea to treat the psoas, but you can't just lie on a hook and have it break up psoas tightness. You have to be able to shorten the psoas and then lengthen it under pressure, which makes a lot more sense. And you can't do that lying on a hook. So if you could flip over on your back, bend your knee, press down on the psoas with a device, and then straighten your leg, now you're lengthening the psoas under pressure, which will give you much better result than just compressing it.
I'm glad you mentioned your book because I know when we first talked about doing this podcast together, you had talked about your book, and I went on Amazon and I actually just ordered it. But for those of you that in the audience, if you're interested in this book, it looks really, really interesting. It's called Muscle Medicine: The Revolutionary Approach to Maintaining, Strengthening, and Repairing Your Muscles and Joints. And it's written by Dr. Rob. And you can get it on Amazon. I'll put the link on here after we edit it. So if people want to grab that book, they can grab it. But that looks really interesting. I'm anxious to read that. But would you say that's more for people that are, the lay person, or are there clinical things in there that a chiropractor can use as well?
I mean, it's really written for the lay person, for the general public, and athletes, non-athletes. But there are things in there that are educational that if you're in the field that you could read about and learn about pin and stretch and whatnot.
Yeah. So if you're not familiar with pin and stretch, it might be a good place to start.
Yeah, it'd be a good place to start. And again, what was really interesting is when I first released the book, people that were teaching pin and stretch were a little upset about it because they said, well, you're giving away secrets of our technique. But what wound up happening is patients would try it and realize it's a lot different between the concept of simple and easy. Like simple and easy are very different. Running a marathon is simple. all you have to do is move forward for 26 miles. But it's not easy, right? You have to train and be prepared. So what happens very often is someone will buy the book, try the protocols, get a little result, and then say, okay, where can I find someone that can do this more effectively? So it's really opened up a lot of people to techniques of pin and stretch. Like a lot of people will call me and say, who can I go to in my area? And then I refer them to the Active Release website where they can find a provider, or I'll refer them to orthopedic massage, or someone who's doing a pin and stretch technique in their area. But Active Release really has a great database that you can go on and find a provider and get someone anywhere, not only in this country, but now they're all through Europe and Australia.
Yeah, I know it's become very popular. Well, Doc, thank you so much for being part of this podcast. We learned a lot of information today. We're going to have you back again to talk about the chiropractor's role in sports injury prevention and performance. And maybe we'll do another podcast after that. That'll be great. Thanks again for being here. Appreciate it.
Thank you so much.
Thanks for joining us on DC Hours. If you enjoyed this episode, be sure to subscribe and leave a review. To explore online courses, seminars, and continuing education opportunities, visit dchours.com. Stay inspired, stay informed, and keep advancing your practice with DC Hours.